the first thing we're going to talk about is cavernous hemangioma, and it's a benign type of liver tumor. Tumor doesn't always have to mean a malignancy, of course. Sometimes people will only have one of them, sometimes they'll have several of them. They can be really tiny or they can be quite large. If they're large enough, you can see a really characteristic pattern, especially on MRI. Here we have a T1 weighted image, and they're usually dark on T1. T2, they're quite bright. They call them light bulb bright. And so that really helps differentiate them from some other lesions that you might be more worried about. And then here's some post-contrast imaging. You see that this, compared to this where it's totally dark, you start to see some contrast enhancement filling in around the edge of the lesion. And as you're taking repetitive sequences through the abdomen after, after contrast administration, you'll start to see that fill in from the periphery, and it'll fill into the center of the lesion like this. And so that's a really characteristic thing that you can look for, and as radiologists, we're confident diagnosing that as a hemangioma. It's not really something that you need to do any surgery for or take care of unless it's really large and the patient's having some, pain or fullness in the abdomen because of this. But it's not something that you need to follow up or do anything about. So the next one, also similarly, you don't have to do anything about these. Hepatic cyst, they're very, very common. This is actually a CT image that these images, by the way, are a little different from the ones that are in your packet. I added some more images just that maybe are a little bit larger and I thought clearer, but these will be available for you too after today. So this is a CT showing this really well circumscribed, homogeneously low density lesion in the liver. As you know, on CT we always measure Hounsfield units when we see something like that. If you get a fluid level attenuation around, say, 10 Hounsfield units or so, you can be pretty, satisfied that this is a cyst. You'll see with time, sometimes you'll see that patients had a cyst and it got smaller or got bigger. They can change with time, but usually they keep this, benign, very well circumscribed, very dark appearance. And on MRI, it'll be similarly homogeneous, dark on T1 and bright on T2, just like all fluid is. And, if you gave contrast for this, you wouldn't see any enhancement in this at all. Sometimes they can be symptomatic, like a cavernous hemangioma. If they're very, very large and the patient feels fullness, they will sometimes surgically resect the cyst. Aspirating it won't get rid of it for good, so they have to really resect the whole wall of the cyst to get rid of it for good. But it's rare for them to be that large. Usually people will never know they have them unless they get a study. This, on the other hand, you can see how these lesions, this is once again a CT, these lesions are also low density, but they're a little bit more heterogeneous. You see that the edges are a little less well defined. If you measured a Hounsfield unit value in this, you would not get a fluid attenuation level. And there's some other worrying findings that you're seeing here. This are some dilated bile ducts. They're, linear branching structures that are not enhancing because the blood vessels are enhancing, of course. That suggests that some of these lesions may be blocking the bile duct drainage from the liver. So when you see multiple lesions in the liver like this, you start to think about liver metastases. And unfortunately, liver metastases are kind of common with certain cancers. They're the second most common manifestation of metastatic spread of cancer. We often see nodules in the lungs, and you can often see lesions in the liver. So patients often with cancer will undergo, repeated sequential imaging to see if there are any lesions, and if there are some, then they'll be treated for a while, and they'll come back and see if they're improving and that kind of thing. On MRI, typically they'll be a little bit hyper intense on T2 weighted imaging, but not as bright as that hemangioma was, and not as bright as a simple hepatic cyst was either. Once you give contrast, they're going to enhance lower than the background liver, just like this. This would be the most common kind of hepatic metastases. Occasionally, some tumors that are very hypervascular, they'll show up brighter than the liver on early imaging, but the vast majority are usually going to be, they're going to enhance less than the normal liver. So a couple of treatment options that they have. Sometimes they just do systemic chemotherapy. Sometimes they do targeted treatments that are administered through the hepatic artery directly into the liver. Sometimes if they're confined to one lobe, they can even take out a whole lobe of the liver if they need to, or just take out several segments wherever the lesions are. It really depends on what the cancer is and what other lesions there are in the body. Here's an example of fatty liver. This is once again on CT. On CT, fat, as you know, is dark. The fat in the abdomen is very dark, and this is the subcutaneous fat here. The liver doesn't get quite as fat as just pure intra-abdominal fat, but you see it's significantly lower than the spleen. And typically, you'll see the liver enhancing about the same as the spleen when we're in the portal venous phase. That's when the portal veins are being opacified with contrast. So if you put a Hounsfield unit measurement on this, you'd find it was very low, and putting a measurement on the spleen sometimes helps you differentiate if it's kind of close and you can't tell by your eye. So that's always helpful. The other thing that's really helpful is MRI, and this slide mentions that CT is the modality of choice for diagnosing fatty liver. And it certainly is very easy to diagnose it, but sometimes the pattern won't be quite as diffuse in the liver. And you can have heterogeneous areas of fat deposition that can even be mistaken for liver masses. And that's where MRI really comes into play. We've used that repeatedly, to try to differentiate, normal liver tissue with fatty infiltration from liver tissue that looks like it has tumors. So what we typically use is an in and out of phase protocol imaging, where you'll have dropout of the signal intensity of the liver on the out of phase imaging as compared to the in phase imaging. Once again, you use the spleen as kind of an internal reference. There are some really complicated formulas that you can use to try to give an exact percentage of the fatty liver, and some machines will have protocols in order to quantify it. But I don't find that that's readily available or usually necessary. As it says here, this is often associated with overuse of alcohol. That can be one cause. You also frequently see it in patients that are undergoing chemotherapy, unfortunately. And it's something that we like to report so that they know to check on the liver functions and make sure that the liver isn't being damaged by the treatment that's supposed to be helping the patient. As well as, it's becoming more prevalent that just being generally obese leads to excess fat deposition in the liver, and that's causing what we call non-alcoholic fatty liver disease, where the liver is, typically remains fatty infiltrated, and eventually that can, in some people, lead to damage of the liver and even cirrhosis in some cases. So the way you treat it is, try to correct the underlying cause, whether it's alcoholism, or if you have to adjust a chemotherapy regimen, or work on weight loss with someone where it's related to their diet. This is one of the most common primary liver tumors. It's called a hepatoma or hepatocellular carcinoma, and it's frequently associated, I added this on top of here, that it's usually associated with hepatitis C in this day and age. If a patient has chronic hepatitis C, they often go on to develop cirrhosis in their liver. Once you have cirrhosis, whether it's caused by hepatitis C or alcohol-induced or other risk factors that cause cirrhosis, you're at risk for having this kind of a tumor. This is one of those lesions that it shows up hypervascular on imaging. So this is a post-contrast MRI, and whereas typical colon cancer metastasis or pancreatic cancer metastasis will enhance less than the background liver, these actually enhance more on the early arterial phase. You can see that most of the contrast is here in the aorta, so you're in an early arterial phase. And because it's so hypervascular, the contrast gets there quickly and it washes out quickly. So we compare the early images to the late images. On the later images, you'll see that the contrast has washed out, and that's very suspicious for hepatocellular carcinoma. And I'm not sure if familiar with the EOVIS contrast, if you've seen that used for liver imaging, that's become a really helpful tool in sort of sorting out cases of hepatoma. It's also been useful in picking up very small liver metastases that were not always detected by CT. It just gives us an extra piece to the puzzle, because every MRI, it has many, many sequences. It's like a puzzle, and that just helps us put it together. So if you were to give EOVIS contrast, you get several delays through the abdomen. You do an arterial and a portal venous and a delayed venous phase. And then you can get, it's optional whether you do a 3-minute phase to see what happens there. And then once you get out into the 20 and 30-minute phase, that's when the hepatocytes start to excrete that contrast. And you'll see that normal liver cells will excrete it, and that part of the liver will be bright, whereas the hepatoma or the metastatic lesions will be dark. So this is important for you guys to know, that this contrast agent only really works well in a functioning liver. And typically the patients who are going to get a hepatoma, they have cirrhosis and their liver doesn't function well. So whereas you and I will definitely be excreting contrast into our bile ducts by 20 minutes, a person with cirrhosis may not excrete enough to create a reliable examination within 20 minutes or even 30 minutes. So sometimes you may have to wait longer. Sometimes it's just, it's not going to ever be useful if their hepatocytes can't process the contrast as well. It won't, cause any damage to the liver. It just, doesn't help with our picture at all. So what you'll be looking for when you do an EOVIS study is to start to see those branching structures, the bile ducts filling in with contrast. And, if you get into a center that does a lot of that kind of imaging, you'll know when to look for it and know when to wait another 10 minutes to try to image the patient again. And like I said before, if you ever have any questions, always call the radiologist and see if it's adequate. The other important thing, like this says, this is in an arterial phase imaging. And in my experience, sometimes patients, I'm not sure if you've experienced this, but sometimes patients, when they receive contrast, and it's actually been shown as being a little more common with EOVIS, that it causes them to feel transiently short of breath. And this arterial phase may end up having a lot of motion artifact in it, which is, makes it very difficult. We could see one like this, but if you were looking for a really tiny one like this, which is important to us, then you want to minimize motion artifact as much as possible. So where I trained, our technologists would always kind of warn the patient and let them know, it's very important that you hold your breath for this, and you're going to feel, warn them that you may feel short of breath, and we want to get really good arterial phase imaging, because without that part of it, it's really hard to figure out exactly what it is in the end. So, that's one way that you guys can really help out the radiologist in just preparing the patient for that, in case it occurs. So once we've found one of these lesions, there are a few different options. One of them is to do a chemoembolization treatment. That's something done by interventional radiology, where they put in some chemotherapy directly into the hepatic artery, and they can also put these little beads that block off all these extra vessels that have grown into around the tumor. And sometimes the beads can be impregnated with chemotherapy. There are also different kind of beads and spheres that have some radioactivity in them that can be used to treat this and other kind of liver lesions. So that's one option. Once again, surgical excision is always an option too. And another option that is frequently used is to do a transplant, because frequently these patients, their liver function is not, it's not up to what it should be anyway. And if they develop one of these small tumors and you transplant the liver out, it usually doesn't have any recurrence of, the hepatocellular carcinoma. Eventually cirrhosis will reoccur, but usually not for, many, many, many years. So, as long as the patient is already a transplant candidate, besides this will actually speed up the transplant process a little bit. There are some guidelines, though. If the lesion gets too large, or if there are too many of them, then they don't consider them a transplant candidate, and they'll go back into those other treatment strategies. So that's why it's really important that we detect as many of lesions that are there, and have good, spatial resolution to measure them well. So this is an MRCP image showing, this is the gallbladder here, these are the bile ducts in the liver, and this is what should be a common bile duct should be not much bigger than these ducts. And this one you can see is just very dilated. So this is known as a choledochal cyst. And these are focal dilatation of the bile ducts. There are several different types that can involve either the common bile duct or the intrahepatic bile ducts or a combination of both. And so, there are different category systems. The patients may or may not have symptoms with this. Sometimes they'll end up getting jaundice and things. Sometimes their liver functions will be abnormal. Sometimes they'll find something palpable, but I think it would have to be quite large for that. And so these are usually just pretty well evaluated by MRCP. Wouldn't need to do any contrast to image this. You just want to give the surgeons a good, good representation of what the relationship is of the cyst to the common duct and the hepatic ducts and everything to plan surgical resection. And even though this may not be symptomatic in some patients, there's an increased risk of cancer with this entity. So even if they don't have symptoms, they do have to do surgical resection, just to prevent that from happening. This is a bit more common than the choledochal cyst. This is choledochal lithiasis. So a lot of patients have gallstones in their gallbladder. Sometimes they won't cause any problem, but sometimes, of course, this is the gallbladder here. Sometimes they get stuck in the gallbladder neck or the cystic duct, and then once that obstructs, the patient would develop acute cholecystitis. Or if they make it out of the gallbladder neck and cystic duct and into the common bile duct, they could get lodged here. So this is a coronal T2 Haste image showing all these little filling defects in the common bile duct. And you can see that they're kind of blocking off the duct here, and further up it's a bit dilated. So usually these patients will present with some right upper quadrant pain, and because the bile can't get cleared out of the liver as it normally does into the bowel, the small bowel, which is down here, the patient, the bilirubin will start to elevate, and they'll won't feel well. Sometimes they can even develop infection from having it blocked off. So, and this is not something that we're good at detecting with any other study. So if we do an ultrasound frequently, because of where the common bile duct is, surrounded by stomach and small bowel, it's often obscured, and we frequently can't see the whole duct in order to see if there are any stones in it. Even if we do see the whole duct, it's not always, you can't always confidently say that there isn't a stone there just saying, just because you didn't see one. And CT is not useful for detecting choledochal lithiasis most of the time because most gallstones are not dense on CT. They won't even show up. So you could see maybe that the ducts are dilated but not know that there's a stone in there until you do an MRCP. So this is something we see a lot of in the hospital. It's a fairly quick test. You don't need any contrast for this, as you know, and it gives them an idea of what the patient needs as far as the next step in management. Usually these patients have to get an ERCP where they go in with they do an upper endoscopy, and they access the bile duct through the small bowel, which is right here where the ampulla empties into the small bowel, and they just put a wire up there and then inflate a balloon down up here and pull all the stones out. Sometimes some sludge will build up in there too, and they'll just clear all that out, make sure that contrast can flow in and flow out of there freely, and that usually relieves the obstruction and makes the patients feel a lot better. These are some images of pancreatic adenocarcinoma. These are CT images. Typically, pancreatic adenocarcinoma is diagnosed and followed up by CT, just because this is a fairly visible lesion as far as they go. But sometimes the lesions can be quite small and quite subtle, and sometimes the spatial resolution of MRI and with a little bit of motion artifact that comes with MR imaging, it can sometimes be difficult to detect them. Now, I'm not saying you won't have studies to evaluate pancreatic masses. You certainly will, but it's just a little bit more common to go with CT. It also helps us evaluate, the relationship to the vessels and see if the vessels are patent, if they're encased by tumor or anything like that. But some things that you may see, if you're ever doing an MRI study, this is something to look out for. This is the main pancreatic duct, and typically you don't see it quite this well. Sometimes you may see it, especially on an MRCP. It's normal to see it, but if you see it very dilated like this, you start to worry that there's something obstructing it in the head, and that's when you start to look for one of these subtle, low density, irregular lesions. That's a typical look of pancreatic adenocarcinoma. Unfortunately, we don't really know what causes it. There's some, theoretical links with these predisposing factors like having chronic pancreatitis and, maybe being exposed to cigarette smoke and that kind of thing. But a lot of times it happens in patients that, don't have any of those risk factors. It's really it's kind of an unfortunate diagnosis. A lot of times when it's made, it may have advanced past the point of being able to do surgery. If it spreads into the surrounding, around the surrounding vessels, you can see it's around some of the major vessels here in the abdomen, and surgeons can take it out to a certain point, but if it's advanced a little bit too far, then then you have options or chemotherapy and radiation treatment. If they are able to resect it, they may do, they'll just resect the part of the pancreas that's involved. Sometimes they just take the tail, sometimes they just take the head, and then they have to kind of rearrange the, how the bile ducts drain and all that. It's quite complicated. And sometimes I've even seen them take the middle of the pancreas and hook the tail up one place and leave the head hooked up where it started out. So they've come up with a lot of new ways to treat it. Unfortunately, it is still a difficult diagnosis to deal with. Some other findings you may see along with it is you're getting a little hint of this. These are those dilated bile ducts. Frequently, these patients will present with obstructed bile ducts, and they'll have that jaundice that I was telling you about people get with, choledocholithiasis. So that's often how they present. The tumors are more common to occur in the pancreatic head than in the tail, and that's why they often present with a biliary obstruction. This is an MR image, a T2 weighted image of a pseudocyst. So you can see a little bit of a thin rim around a very homogeneously T2 hyperintense structure here. This is in the lesser sac behind the stomach. And what happened with this patient is that, at some point in the, recent past, he's had some kind of acute pancreatitis episode. And sometimes acute pancreatitis can resolve without any sequelae, and sometimes you'll have fluid collections develop. Now, there are two phases of fluid collections that we differentiate: the acute peripancreatic fluid collections that occur in the first 4 weeks, and then the pseudocysts that really form a kind of pseudo wall around themselves and stick around a lot longer than those little acute fluid collections that sometimes resolve on their own. Usually, patients with acute pancreatitis present to the hospital because they've had a lot of pain with the pancreatitis, and they'll have imaging at the time of presentation, and they may have repeat imaging afterwards to follow up a pseudocyst. And MRI would be a good way to follow up pseudocysts because you can see them beautifully on T2 weighted imaging. MRCP is really helpful to depict the relationship with the pancreatic duct and see if there's been any disruption of the pancreatic duct due to this pancreatitis. And either CT or MRI is good, useful in kind of planning an approach if you need to aspirate this cyst or try to get the fluid out of it if the patient's symptomatic or if it's getting larger. There are a few different ways you can get rid of a pseudocyst if you need to. One would be to do a percutaneous drainage. We do a lot of drainages where you just stick a needle in under CT guidance and put a drain in there until all the fluid is gone. You have to leave it there for a while, make sure it doesn't accumulate. You can also some gastroenterologists will do this with upper endoscopy. They can create a tract from the cyst into the stomach so that it just drains into the stomach fluid and goes out naturally that way. But some will need surgical resection to really clean everything out and take care of it. It all depends on patient to patient. And these can occur anywhere in the abdomen. They don't have to be right next to the pancreas. Normally they are, but they can, you can see them occur near the spleen or, down in the subhepatic space. They can really show up anywhere when someone's had acute pancreatitis. You just kind of have to wait and see if they go away on their own. And these are just images, MR images showing what acute pancreatitis looks like, maybe in that patient the day he came in. This is another one that we frequently diagnose by CT. Usually the patients show up in the emergency room and they don't have abdominal MRI available, so they'll go with a CT. But these MR images are showing that there's a little bit of this. This is the pancreas here. It kind of has a little bit of an edematous appearance. It looks like there's some fluid tracking into it, and there's some fluid around it. Here's a T2 weighted sequence that shows some inflammatory fluid, not bright fluid like that pseudocyst fluid collection. This is more in the acute phase before it's formed those well walled off fluid collections. So this is a good time to look for any acute fluid collections that you may have to keep an eye on in the future. MRI can also be really useful to try to figure out the cause of pancreatitis. The more common cause, of course, is alcoholism, but sometimes this can also frequently be caused by gallstones. As I showed you with the choledocholithiasis, sometimes if a stone is lodged down there in the common bile duct where the pancreatic duct drains in, it can block up the pancreatic duct as well, and that will cause inflammation of the pancreas. Sometimes even the procedure that they use to remove gallstones, the ERCP procedure, can result in pancreatitis just because of their manipulating the area and manipulating the duct and all that can cause a post-ERCP pancreatitis. Rarely, if a patient have extremely high triglyceride levels, that could result in pancreatitis. And there are a couple of anatomic normal variants that can predispose you to pancreatitis, such as pancreas divisum, which is an aberrant ductal anatomy. And MRCP is really helpful in helping us figure out where the ducts are draining and make sure that there isn't that kind of an anatomy that predisposes the patient to recurrent bouts of pancreatitis. One thing that we do sometimes in the case of trying to figure out ductal anatomy is to give secretin. That increases the secretion of pancreatic enzymes from the gland after you inject it. So what you would do is you'd do an MRCP, and you choose a plane where you can see the pancreatic duct well outlined and it's not overlapping with a common bile duct, so you can really get the relationship once you inject it. So it really kind of opens up the duct, and you can see the relationship well and see where any side branches are going and things like that. As far as treatment for pancreatitis, the treatment is really it's really symptom management and dealing with the complications of it. Like I said, you may get pseudocysts and need to drain those. You're going to have to support patients with pain medication. It can be a very painful process, and occasionally they will get thrombosis of the vessels in the area, so they may need anticoagulation. Sometimes patients can be very, very ill with this and need to go to intensive care. Sometimes they actually resolve quite quickly and go home after a few days. So this is an example of polycystic kidney disease. You can kind of see just a bunch of cysts, and they're almost in the shape of a kidney. You can imagine this used to be what a normal kidney would look like. This is a T2 weighted image, so most of them are bright on T2, just like fluid should be. But you also see ones that have a little bit intermediate signal intensity. They can have sometimes some proteinaceous content that will change their signal characteristics. They can also sometimes bleed into these cysts. I believe rarely, very rarely, they could become infected. And sometimes they can even develop in amongst all these cysts. Sometimes renal cancers can develop. So it's kind of a challenge to image and try to figure out what are cysts that are not nothing to worry about, and what are things that we need to keep an eye on. these are the kind of kidneys that you know, if the patient's able to take contrast, you know, you want to try to do a contrast-enhanced study if you're able to. Frequently, however, these patients, because their kidneys are being replaced by cysts, they frequently can't tolerate contrast administration either for CT or MRI, and many of them will need to go on to eventually be on dialysis or have a renal transplant. Many times they'll leave the kidneys, they'll leave the native kidneys where they are, sometimes because they can get very, very large and cause a lot of mass effect in the abdomen, they do sometimes resect them. Once you resect them, of course, you don't have to worry about monitoring for any kind of malignancies. This is, you know, a genetic disease. It's, you know, it can be passed down, but it's not very common. We do see it, but it's not very common. The other thing you'll see along with these renal cysts, we've kind of changed the name in recent times to calling it adult polycystic disease, because it doesn't always just affect the kidneys. You can often see those liver cysts like what I showed you earlier, those hepatic cysts, but you'll just see tons and tons of them kind of like in the kidneys. So those can often go together. You can also see cysts in the pancreas frequently, but not as often as you see co-occurring hepatic cysts. Now, in contrast to the renal cysts, the hepatic cysts don't seem to affect the function of the liver. The liver seems to function quite well, even if it seems like it's been completely replaced by cysts, it continues to function. So those patients really don't usually need to go on for a liver transplant. They may sometimes have to have some of the cysts resected in order to create space in the abdomen, just, you know, like someone that may have just a single large hepatic cyst. But usually the liver function can keep up. The liver is a very resilient organ. So this is an example of a tumor that you can get in the kidney. Renal cell carcinoma is the most common tumor that you can have in the kidney. This is a CT image showing, you know, this is the normal kidney here, and then you see this low density, kind of bulgy looking area back here. That's the tumor, of course. These are usually centered in the cortex. I don't think there's any definite known risk factor to them. They just kind of show up. They usually show up in older patients. Many times they grow very slowly even when they show up, so it may take a long time for the patient to present. Sometimes they'll feel some pain. Sometimes it'll be just incidentally discovered on imaging. And you know, this one, it looks fairly solid and is enhancing, not as much as the kidney, but certainly more than a cyst or renal cyst would. This is an MRI example of one that is a little bit trickier. So this one is, it looks a little bit low signal intensity, like you would expect a cyst to. And likewise on T2 weighted imaging, this would be mostly homogeneously bright in here. But you look for these septations, and you notice that they're enhancing as brightly as the kidney does, and that's a worrisome feature. So sometimes these can look like a complex cyst, but once you see something that breaks enough of the rules, like having an irregular border and having a thick septation that enhances, or having any nodularity to it, you have to become suspicious of one of these renal cell carcinomas, because they can sometimes look cystic. And unfortunately, CT and MRI can't tell you until you actually get the tissue out. So these patients will often have a partial nephrectomy these days if the lesion is small enough. These ones that I'm showing you are quite large, but frequently we catch them a little bit smaller, so they can just take out that little piece of the kidney. Sometimes if it's really not involving the meat of the kidney, you won't even notice that they've done it. You'll just see a little divot there, and the patients do quite well. Sometimes it requires taking the whole kidney out. Another option that they do sometimes is use a cryoablation. They put a probe into the lesion, and you just kind of create an ice ball that cools off the whole lesion, and it basically freezes it until the tumor is gone, and then you monitor them with imaging afterwards to make sure it completely resolves. That's for patients who aren't great candidates for surgery. MRI is very useful to characterize these lesions, and it's also helpful to evaluate for any involvement of the renal vessels, look for any lymph nodes in the retroperitoneum, which would be the most frequent location for local spread. You will have to go to CT to evaluate the lungs, and maybe a bone scan to make sure there are no bone lesions as well. the survival for this depends on staging at the time of diagnosis, but now that we image people a little more frequently, we're catching these early, and a lot of patients, they do quite well. Sometimes in older patients, now that we're seeing how slowly they progress, if a patient is older and they have other comorbidities, say they have heart disease and maybe they have emphysema and things like that, they may opt to just watch these lesions and see if anything's changing with time before they jump on doing surgery. That's becoming a new approach to watch and wait. And so I've seen some of these lesions change very little within years and years. So.
Question?
Sure.
The 30% dead rate, is it with opportunistic disease or is just with renal cell carcinoma like I said?
30% of?
You said 30,000 new cases are diagnosed annually in the United States. With about 12,000 deaths.
Yes, I'm not
sure.
So
that's about 30%.
Yeah,
it
sounds.
Is it with people with opportunistic disease or just primarily?
Yeah, I'm not sure if some of these statistics may be a little bit, the epidemiology may be a little bit skewed towards older data, because it seemed like some of these, some of these outcomes seemed a little bit more bleak than I think things have become lately. So yeah, I wouldn't anticipate, that a third of people who are diagnosed with it will die from that cause,
That would be scary.
Yeah, it would be. That would be a lot. Certainly it's something you take seriously, but perhaps more recent data would show a less serious chance of death.
And for a patient with the current disease, the polycystic kidney disease,
Mm-hmm.
if you have bilateral polycystic kidney disease, would they remove?
Yeah, if you have polycystic kidney disease, it basically will always affect both kidneys. Yeah, and so the decision on whether to take either one of the kidneys out or both is often based on a mass effect, how much space it's taking up in the abdomen, because sometimes they can get extremely large and they're taking up a large amount of the space in the abdomen. And it's a big surgery to remove kidneys, but if there's really no space in there, they may often have to remove them for that.
So polycystic kidney disease is not cancerous, is it?
It's not. No, it's not. It's not. But it is, it is a risk factor for developing renal failure and having to go on dialysis and or have a kidney transplant. A lot of those patients end up having a kidney transplant, in fact.
Yes.
Sure. Here's another entity that can affect the kidneys. These are renal infarcts. This is shown on CT again, but this would be similar to something that you would see on a post-contrast to, say, T1 weighted MRI image, where you can see the normal kidney. This is the cortex of the kidney that's enhancing very nicely, and then you see this area of just gray. Nothing is happening here. So that suggests that you have a renal infarct. Sometimes it'll be a large area like this. Sometimes it'll just be a little wedge taken out like this, or maybe multiple wedges. A couple of risk factors for this. Sometimes you can be showering little emboli that come from, say your heart, if you have, an arrhythmia or, other risk factors that cause septic emboli. They'll just block off some little blood vessels to different parts of the kidney and cause an infarct. Or in the case of this one, I believe this was a post-traumatic one, where sometimes the renal artery can become injured from trauma. It can get a dissection in it. And the patients they'll sometimes have pain with it. Sometimes it'll just be found on imaging that was done for other reasons. And sometimes the kidney will recover, especially if you can isolate a cause and maybe open up the blockage before the kidney really completely dies off, that part of the kidney. Sometimes it's not salvageable and you will lose function of one kidney or not. As you know, people can live with one kidney and the other one often gets larger and compensates for it. So where MRI will come in with this is often to evaluate the vessels. So sometimes you'll have to do an MRI to see if the vessels are patent. CTA is also an option to see what's going on with the main renal vessels. So this is so a couple of images of an abdominal aortic aneurysm. This is a result of weakening of the arterial wall, as it says here, from atherosclerotic disease. Atherosclerosis is just a buildup of plaque in your arteries that can happen from, say, smoking or having high cholesterol, that kind of thing. A lot of people who don't have high cholesterol won't develop these, so sometimes there are some patient factors involved in who gets them and who doesn't. There are some genetic conditions that predispose people to aortic aneurysms as well. That usually your typical patient is going to be an older patient. Sometimes they'll have pain or feel fullness, or the doctor may be able to feel a big kind of pulsatile mass is what they describe. If you can feel a large area in the abdomen that you feel the patient's pulse on it. Sometimes they just look for these with screening tests. If they know a patient's been a smoker for a long time, say, they may just start out with an ultrasound to see make sure that the aorta isn't getting dilated. The risk of this condition is, there are two risks. One of them is, as you can see, the normal aorta would be much smaller than that. If it gets big enough and the wall is weak enough, it can actually rupture. And the aorta is your main blood vessel to your whole body. So if it ruptures, the blood comes pouring out of there pretty quickly. It is possible to have your aorta rupture and get to hospital fast enough to have it repaired. They do emergent repairs all the time. Sometimes they can do them endovascularly, where they go in through the vessels and put a stent across it. Sometimes they have to open the patient to do it. The other risk is of getting an aortic dissection, where a piece of the wall kind of peels off from the inside, and then the half that's not getting blood flow may lead to occlusion of one renal artery. Let's say it'll kind of split blood vessel in half. You may end up with occluded renal artery and occluded superior mesenteric artery that goes to the bowel, that kind of thing. So that's a risk as well. That can also be fixed with an endovascular repair. They just put a stent in across the area of dissection. As far as MRI goes, you may be using MRI to evaluate an aneurysm, either for screening or to evaluate for progression of them. It's physician dependent which kind of study they prefer. Frequently we do see CT used for this, but you can see that they can do some really beautiful MR images of it. This is the part of the aorta that's kind of become focally dilated distally. This one's not quite as big as these ones, but it's still something you want to keep an eye on. Sometimes if they see it get to a certain size, because of the risk of it rupturing or of getting a dissection, they'll just say, hey, when it gets to 5 centimeters, we're going to do something about it. Usually an endovascular repair, where they just put a stent across through the vessels. These images are showing renal artery stenosis. Atherosclerosis can affect the small vessels as well as the large vessels like the aorta. So the renal vessels are at risk of being narrowed and eventually occluded. Naturally, if your kidney is not getting enough blood flow, it's going to start to become atrophic and it will shrink down. It won't function as well. So this is a cause of renal failure. It's also, before it gets to that point, it's an important cause of hypertension that can't be controlled with normal means. So sometimes if they see that a patient has hypertension, they've tried a lot of different medicines, and the kidneys are still functioning, so they don't have an explanation for it, they may ask you to do an MRI to evaluate the renal arteries. We can also evaluate this with CTA as well as ultrasound. The ultrasound is not as reliable, but MRI really does show nice images of the renal arteries. The arrows are pointing to some focal areas of narrowing. Sometimes this is a little bit controversial in recent years, but sometimes if you put a stent across that and open it up, it may help save that kidney if the kidney still has good function left, and it may help with that hypertension if it's an uncontrolled hypertension. Usually this is caused, like I said, by atherosclerosis. This fibromuscular dysplasia that they mention is just a kind of sporadic mutation that I think it's seen in families, but it just results in multiple areas of narrowing along the vessel. It's not very common. The more common reason that you're going to see this kind of narrowing is from atherosclerosis, just the same things that cause heart disease and strokes and all the troubles that we have with our vessels as we get older. This is just a couple of images showing a really, really large spleen. I'm sure you've seen lots of normal scans where the spleen was nowhere near this size. In this picture, it looks almost as big as the liver, and in this one, it seems like it's even bigger than the liver itself. This can be caused by, most frequently, it's caused by portal hypertension. So, if the blood is not flowing well into the liver, then it backs up into the splenic vein and makes the spleen bigger. And sometimes you'll even see collateral veins around the spleen trying to decompress all this blood that won't go through the liver. The reason that it wouldn't go through the liver is, say, from cirrhosis. If the liver has become kind of fibrotic and scarred down, then the blood doesn't flow through the liver as well. It tries to find pathways around it. And so, you start to see changes of an enlarging spleen along with those early changes of cirrhosis, then you need to alert the clinicians with imaging that the blood flow patterns are starting to be altered here. Once you see that, you'll start to look for some, the collateral vessels around here. They'll get varices around their distal esophagus, which they're at risk for bleeding from, or around their stomach. And they're also at increased risk of rupturing the spleen, especially if they have any trauma. There's some other, the more common causes that cause a really enlarged one like this would be hematologic malignancy, like a leukemia. So usually those patients with treatment, the spleen will get smaller. Unfortunately, with a cirrhotic patient, the spleen will not get smaller. It will stay large. They're not really at as much risk for a rupture as when it's this large, but the spleen will usually stay large, even if that patient ends up getting a liver transplant. We try to look for any focal lesions, but usually it's fairly homogeneous. This pattern of enhancement, this is just the normal way that the spleen perfuses kind of early on in the early portal venous, kind of late arterial phase. This is a Wilms tumor. This is a tumor of a pediatric age group and very rarely occurs in adults. These patients usually present with large palpable mass. The kids don't always complain of pain, but the doctor will feel on examination. They feel some major fullness there, and this is the normal kidney on the left side, and on the right side, it's kind of been replaced by this big, very heterogeneous mass. And this, you can see just a little bit of rim of normal kidney around it. So these tumors usually present when they're quite large, and you do have to do surgery to remove it. And the kids actually do quite well. They'll have to have surveillance imaging for a long time, and we like to use MRI in pediatric patients as much as possible just to decrease the radiation exposure. So you'll probably be seeing these, at the time of diagnosis and also for follow-up in the future. This is another entity that MRI is particularly useful for. Patients who have uterine fibroids can have a lot of different complaints, pelvic pain, fullness, excessive bleeding, and that kind of thing. Our test of choice to start with, on the uterus and the ovaries is usually a pelvic ultrasound. But unfortunately, these kind of these fibroids, the tissue is dense and the ultrasound doesn't penetrate them very well. So sometimes it's really hard to determine, the relationship of the fibroid to, say, the endometrium, which is here, or, the serosa of the uterus, which is here. And that helps us figure out kind of, what's the best treatment strategy for this patient. So MRI is very useful for imaging these. The treatment options for the lesions are, there's several. Sometimes surgeons will just kind of, take out one or two large lesions, and that may alleviate the patient's symptoms. Sometimes interventional radiologists will go and block the blood vessels that go to the uterus, and that will decrease the blood supply to the fibroids enough that they shrink down, but the uterus will still have enough blood supply, and you don't have to do surgery in that case. And sometimes they end up just doing a hysterectomy for them. As far as the signal intensity, they can vary a lot in signal intensity. It kind of depends on what's going on with them. They can kind of become necrotics, and have varying signal intensity. But but usually they kind of confine to the area of the uterus, and you can usually tell that it's a fibroid even if it's a little bit heterogeneous.
So on the patient with reproductive age,
Mm-hmm.
if they remove the tumor,
Right.
are there possible side effects?
That's a good question. So if you have a patient who's of reproductive age, this can actually contribute to infertility in some cases. So if you have a patient that's having difficulty getting pregnant with a fibroid, they may opt to do the surgery that's called myomectomy, where they leave most of the uterus and just try to take out a few of the larger fibroids. And in recent years, they've also found that doing that uterine artery embolization treatment that the interventional radiologists do, some of those patients have gone on to become pregnant as well, even after the treatment. Now, they don't recommend it they generally don't recommend that patients do that if they're still trying to have children, but sometimes patients, they don't have an option, they haven't been able to conceive, and they may not have a single lesion that they can take out and restore fertility. So it wouldn't be the first thing that you would go to, but sometimes that can end up restoring fertility. And for a patient who is past the age of fertility, sometimes women, even though they're symptomatic from it, they may not want to undergo a surgery like hysterectomy, which is still a fairly major abdominal surgery. So it's another treatment option. But the MRI is really important in order to show where they are in that case, because certain types of fibroids will be at higher risk for becoming infected if you use the uterine artery embolization. So it's really important to know exactly where they are in relation to the inside and outside of the uterus and everything before you opt with any of the treatment.
So does this have to do with gene or what? Because I see that black women are more affected 3 times than white women.
Oh, like genes? Yeah, I think they do. It does. It is partially genetic, because you see that it kind of runs in families a little bit too. But many women, it'll be sporadic where they don't have family members, or plenty of women of all races will be affected by fibroids. So these are some images of an ovarian cyst. Ovarian cysts are pretty common. Every woman, during the cycle will be kind of developing cysts that they call follicles when they're small, and then they rupture and release an egg. Sometimes they don't rupture, or sometimes a cyst forms that didn't have a follicle in it, and then it becomes an ovarian cyst. Our cutoff for a measurement of what we call a cyst is 3 centimeters. The first imaging test you would go to is ultrasound, of course. Many of these you can see on ultrasound well and see that they look like just simple fluid, and once you follow them up, they'll go away on their own in several months. Some of them will stick around for a long time but not change at all. But sometimes you'll see things on ultrasound that may make you feel a little bit more worried, like you want to get more evaluation, for example, with MRI. Some of the things we look for on ultrasound and that we further evaluate with on MRI are similar things that I told you about the renal cyst and the renal cell carcinoma. If you look for enhancing septations, thick septations inside it, or nodular wall, or multiple locules, just kind of picture that renal cell carcinoma. If you see any of those features in an ovarian cyst, you want to be suspicious. You probably end up doing a follow-up study sooner rather than later. And many women will go on to have an ovarian cyst removed if they can't definitively characterize it as being benign, or if it changes quickly with time. The other risk, if they get large enough, sometimes they're at risk for causing the ovary to twist or cause ovarian torsion, where the blood supply can get cut off if the ovary twists. So they may have to take them out for that purpose. And sometimes it's just because the patient is experiencing pain related to it, that they can get large enough and cause symptoms. But the major thing that we're worrying about on these kind of imaging studies is look for those suspicious features to make sure it's not a malignant kind of cyst that we would want to take out and try to avoid missing an ovarian cancer. They often, the early ovarian cancers, they often look cystic, but they'll have those suspicious features is what we're looking for. So you'll probably be seeing some pelvic MRI to follow-up cyst that looked a little bit funny on ultrasound. This is an example of a uterine anomaly that just happens during development, kind of intermittently happens to different people, where the uterus, instead of forming a normal kind of triangle shape, it makes this little bit of a heart shape here. You can see that it has a divot in the top. It should normally be flat across the top like this. And you can see that there are two horns. There's one horn here, and there's one horn here. And when you look at it in the other plane, it looks like, two separate horns here. So MRI is really important in diagnosing this because the uterine structures are not well defined on CT. It usually just looks like kind of a gray blob, and it's not easy to tell exactly what the shape is. As well as with ultrasound, we're getting better now with using 3D ultrasound to help diagnose this, but really the test of choice for confirming this entity is to do a pelvic MRI, and you'll be doing imaging in the plane of the uterus to get a really nice heart-shaped picture like this, so you can make a definitive diagnosis of this. Once you identify a patient with a bicornuate uterus, they'll kind of keep an eye on that patient if they become pregnant, because they're at a little bit extra risk of having a pregnancy loss or having an early birth, or some kind of unusual presentation of the fetus, so they may have to go to a C-section more frequently than someone with a regular uterus. But patients are often able to get pregnant with this uterus. There's another kind of similar looking structural anomaly, which they will still have a flat top across like a normal uterus, but they'll have this division coming down through the center of it. And that's not to be mistaken for this heart-shaped one. That one's called a septate uterus. So it's normal shape overall. It just has this septum that's going down the middle. And it's important for us to recognize that as well, because the septum may be come down very low or partially. Depending on how low it comes and whether it's interfering with fertility, they can resect that septum surgically. So it's important to use MRI to characterize these things. There's no surgery for the bicornuate uterus. You just need to monitor the patients carefully when they become pregnant. This is another more rare anomaly. You don't see this frequently, where the two horns are not joined at all. They're just completely separate, and it's called uterine didelphys. Once again, MRI is really helpful for showing that these are two completely. They never join in the middle there, and they would have this separation down there, low signal intensity separation that goes all the way down. They may have two cervices. They may have even two vaginas. That has occurred as well. So once again, there are some increased risks of losing pregnancies and early birth and things like that. Usually the patient, but frequently the patient will carry a pregnancy in just one or the other horn, just like with a bicornuate uterus, and it may be able to accommodate it. So this is another one where you just have to monitor the patient carefully and see how they do.
So in this instance, would the chromosomal test would be able to predict it?
No, this is not a chromosomal abnormality. This is usually kind of just a sporadic thing that occurs, with part of the normal when an embryo is forming, in someone else's uterus, in the mother's uterus. As you're forming, there's tons of structures coming together, coming apart, forming this, forming that, and if things don't go exactly perfectly, you'll get some anomalies like this. There was a medication that was linked to a uterine anomaly that was given for what do you call it, morning sickness, way back, I think in the 60s or 70s, and the women, many of the babies born to those women who took the medicine had a T-shaped uterus, but that medication it was used for a very short amount of time, and we haven't used it for a long time, so you really don't see women with that T-shaped uterus anymore. So it's something you kind of learn about historically, but not something that you'll probably end up seeing in this time.
So the double uterus would be like the opposite of hermaphrodite?
Oh, no. They're still women. They're still 100%, women. It's a uterus just like any other woman. It's just that their uterus didn't, completely join the way that they do. But they, have ovaries and normal female hormones and everything, and they can, frequently carry a pregnancy, and it's just their uterus is shaped a little different. This is an example of cervical cancer. Obviously it's a malignant tumor that occurs starts out in the cervix and can spread outside the cervix. Unfortunately, sometimes kind of getting into the lower portion of the uterus and into the soft tissues around the uterus. MRI is once again really useful in delineating the extent of a cervical cancer, so that they can plan whether this is something they can treat surgically or whether they need to do just radiation treatments or chemotherapy treatments. It's really important because like with CT, it kind of becomes a big gray blob down there, and MRI shows beautifully any extension into the fat, any lymph nodes in the pelvis that may be involved, the size of the tumor and the relation to the uterus and everything. It's very, very helpful. This cervical cancer is really frequently caused by a human papillomavirus infection. That's what puts women at risk for this, and that's what they go to the doctor every year for, or every 3 years now is the recommendation, to get a pap smear and try to detect it in the early stages, long before it would become anything like this. Now, as we've developed vaccines for the HPV infection, we're hoping that we'll see this cancer less and less frequently. So hopefully you won't be doing too many of these studies for cervical cancer in the future.
You see, the vaccine is a little bit controversial.
It's a little bit controversial. I think people become a little bit worried about the fact that HPV is something that is sexually transmitted, and so the controversy exists as whether you should give it to children when they're getting their normal school vaccines, knowing that they're not going to be sexually active and that you don't want them to become sexually active. So that makes people a little bit uncomfortable, but hopefully with time we'll get comfortable with the fact that we just don't want anyone having cervical cancer and just throw it in with the regular vaccines. Here's something that happens frequently in older males, prostate cancer. This is something that's kind of hard to detect. They have a blood test for it that they often check at the family doctor, usual routine physical visit, called a PSA test. And if they see it elevated, they'll usually, the next step will be to take some biopsies of the prostate. So these are some MRI images of the prostate. Like with the cervix, the prostate just kind of looks like a gray blob on CT, so it's not great at differentiating structures and it's not great at finding cancer. That being said, we're still in the early stages of optimizing, detecting and understanding prostate cancer with MRI. But in certain cases, if you're not, if a patient, they have a way of scoring all these factors, and if a patient's in the gray zone where they're not sure if they should treat him with radiation versus doing surgery, then MRI can really help sort out whether this tumor has spread outside the gland or not. So typically the patients who come for this study already have a known diagnosis of prostate cancer based on biopsies that a urologist would take. So this is the prostate gland. Here are your hip joints and everything, bladder. And there are a couple of different zones, the peripheral zone of the gland and then the median lobe of the gland. And the peripheral zone should usually be a little bit, especially, I'm going to point to this image because this one is done, it's a little bit better definition because we're doing this with an endorectal coil, which is, I don't know if you've ever seen one of these done, but you do have to put in an endorectal coil to get really nice detailed images. So you can see this is the central part of the gland and this is the peripheral zone of the gland. And on this side, you can see it's very bright. These are a T2 weighted images again. And you see in this area, you see this really kind of infiltrating, poorly defined gray area. And that represents, the primary tumor. Now, usually, as I said, we'll know that the patients have prostate cancer before they come in. So we're not doing this study typically to detect the cancer. What we're trying to do is see if there's any spread outside the capsule, which you can see, the edge of the capsule of the prostate. So sometimes you'll see the tumor will even be bulging the capsule out a little bit. If you see even a little bulge there, then the urologist needs to know about that. Or sometimes it invades the seminal vesicles, which are a little bit higher up in the pelvis. Or you can see malignant lymph nodes in the pelvis. So it really helps the surgeon sort out whether, if you see any spread like that, then they're going to go down the path of radiation rather than doing a prostate surgery to take the whole prostate out. So you may, some centers do a lot of these. Some don't do as many, so I'm not sure how many of you will see them. We didn't do a lot of them in my fellowship, but occasionally we were called upon to try to sort out a patient's case.
What's the possible side effect of the radiation in this case?
The side effects of having radiation, the prostate often gets smaller with radiation. As far as symptoms and things, you probably wouldn't have a lot of symptoms. Anytime you expose someone to radiation, you worry about the risk of causing other cancers. But if you have a cancer already, then, usually you go ahead and just do the treatment that's going to work with it. And then, there's always the risk of it not working and it not taking care of the tumor entirely. But, a lot of patients are doing better with prostate cancer. This is another one where they may be a little bit conservative if the patient is older because they found that it doesn't always progress to be something, life-threatening as far as, in patients that have other comorbidities like heart disease and things like that. So that's the end of the abdominal imaging part. Let's go over some brain imaging next. Sorry, this is taking a while. All right, so this is just going over, some general characteristics of T1 and T2 weighted imaging versus CT, which I think you guys are probably pretty familiar with by now. I'll tell you in general, if you're looking for, things that are bad, something like that's intermediate on T2 weighted imaging is usually going to be suspicious and dark on T1. So that's what we're often looking for. Stuff that's usually really bright on T2 is not too bad, and really dark on T1 is not, but that intermediate zone starts to make you worry. And this is just showing you some of the characteristics, with infarcts, bleeds, and that kind of thing. Tumor, like I said, a lot of the things that are a problem, you notice that are bright on T2 and dark on T1. CT is just not as sensitive to, to finding some of these things. So MRI is a much more sensitive test for abnormalities in the brain. So the first thing we're going to talk about here is brain metastases. Like in the liver, often cancers can spread to the brain. Sometimes it'll be just a single lesion that you'll see. Sometimes you'll have many lesions all around. It's kind of easy to figure out if you see a lot that it's a metastasis from some cancer. And this may be the patient's first presentation. They may have a seizure as their first presentation, or headache, or some kind of neurologic abnormality, like they feel, they end up with weakness or something like that, depending on the size of the lesion. Frequently with certain tumors, you may start out imaging a cancer patient, just check their brain, make sure there's nothing there, and then just do follow-up as needed if the patient gets any new symptoms. CT is not terrible at detecting these, but we really prefer to image for brain metastases with MRI, and when you do it, you have to do it with contrast. Frequently, a metastasis will just start out as a tiny dot here, so you really have to comb the images for it, and it'll just be one tiny contrast-enhanced dot, and you may have very little, signal anomaly on the other sequences. Usually it'll be, a little bit of T2 brightness, a little bit of flare signal abnormality, but the contrast imaging is really key to finding these lesions. We usually do our post-contrast imaging in at least 2 planes, to make sure that you see all the lesions and, can really keep in get an idea of what size they are in 3 planes and that kind of thing. And then once they start treatment, then we can evaluate for change in size and change in number of lesions well. So we'll do some kind of thinner section imaging, T1 weighted imaging after contrast The way that they treat brain metastases, it depends on what they're from and how many they are. If they're kind of all over, they may end up just doing a whole brain radiation, kind of control things, keep them back. If they're a single lesion, they may resect them. They do have image-guided, they call it stereotactic radiosurgery, where they do really highly directed radiation beams from many different angles, and they converge on one lesion, and they'll just treat that area with a large dose of radiation. And since they're passing through the brain at many other angles, that creates a lot less overall radiation exposure to the normal brain tissue, because like I said, the risk of having radiation exposure is you don't want to develop another tumor from exposing your brain to the surrounding tissue to radiation. So that's not very new, but it's the past decade or so, it's become really common for a way to treat if there's just a few lesions. And of course, MRI will be really important, not just in detecting whether those lesions get smaller and go away, but sometimes it can be difficult to detect, especially with CT, when you're dealing with post-treatment changes from that kind of a treatment versus a recurrence of tumor. And using the different sequences with MRI can really, really help you solve that problem and sort out whether you're dealing with something recurrent, whether the patient needs another treatment or not. So you'll definitely be doing a lot of these for brain. The time that you may want to alert the radiologist, you may get alarmed about it, is if you see that one of the lesions is very large, it's kind of pushing structures this way to one side to the other, down, or really creating a lot of mass effect, we call it, in the brain. They may want to know that sooner or later, especially if you're in an outpatient imaging center, so that they can keep the patient there and maybe get them into the hospital, just to get things moving as far as decreasing, because you don't want things being moved around too far in the brain. There's not much space. It's a confined space. This is an acoustic neuroma. It's a type of fibrous tumor that occurs around one of your cranial nerves. You've all these cranial nerves in your head. You could get tumors of any one of them. This one's a really characteristic one as far as location and as far as the imaging appearance. So this is a T1 weighted image where they're pretty well circumscribed, and you can see it extending. This is the internal auditory canal. And after you give contrast, it enhances really brightly, and you can see that relationship of it going into the internal auditory canal. And sometimes you only just see it, kind of pooching in a little bit, and it can be difficult to detect. So when you see a lesion in this area, you may want to make sure that you're getting thin enough sections to it, so that if you do have that relationship with the internal auditory canal, then you can say it with pretty definitively. Because the other lesion that can occur in this location, this is known as the cerebellopontine angle, is a meningioma. And a meningioma is similar, kind of iso-intense on T1 weighted image, and really enhances brightly with contrast. In that case, it will not extend into the internal auditory canal, and you may see this slight dural tail. I'll be showing a meningioma later, and I'll show you that dural tail. But these are kind of subtle findings, subtle structures that that we'd like to see some thin section imaging. Usually, before the patient comes in, they know based on the symptoms, the cranial nerve symptoms, that this is what they're looking for. But sometimes, it's a surprise, and they're not sure. And so, if you see one in there, maybe just check with the radiologist, make sure they're getting enough imaging through it to give them a definitive diagnosis of which one it is. Because this is one we can actually sort out by imaging. The symptoms that people will have is, hearing loss, ringing in the ears, dizziness, because it's involving those nerves that go to the ear. And they will do surgery for this. This is a glioblastoma. It's a type of an astrocytoma, really the most aggressive type of astrocytoma. It's a very, very rapidly growing, very aggressive tumor, unfortunately. Many times the patients will present with a seizure or something like that, kind of a dramatic presentation. You don't usually have one of those for very long before you know it. They get large quickly, and the notable thing about them is they induce a lot of edema. So this is a T1 weighted image, and you can see that the mass is here. That's fairly low in signal intensity, and then you see this kind of intermediate area that's not quite normal for the white matter in the area. This is all some edema around it. And if this were a T2 weighted image, of course, you'd see kind of a T2 hyperintensity all around it. Sometimes the edema can be really extensive, and you'll see the brain will be very swollen, and this whole area can smush the lateral ventricles over to the side, can really create a lot of mass effect. So that's another time, where you'll be looking out and see how much edema is there, how much compression is there in the brain, and, alert the radiologist if you see that coming through so that they know to take action quickly. Because you can decrease that edema quite quickly by giving them steroids, and then take care of treating the tumor after that. But, as far as getting the patient, their neurologic symptoms and, the mass effect under control, steroids can be helpful in very short term. So, like with most tumors, you're going to want to do post-contrast imaging with this. Of course, if you ever see, any mass lesion in the brain and you're looking at a non-contrast study, you want to see if they want to add contrast onto it. They enhance really brightly around it. Central areas that are not enhancing may be necrotic, where the tumor has outgrown its blood supply and it kind of starts to die off in that area. You may sometimes see other lesions in the brain. They can spread along the white matter tracts. They can even spread from left to right. And they can sometimes occur just in multiple locations at the same time, although that's less common than a single lesion. And what they do is they do surgical resection, and then they also do radiation treatment and chemotherapy to the area. And that can usually control it. It doesn't have a good prognosis, unfortunately, and things often don't stay at bay for very long. But there are treatment options, at least to keep them around for another couple of years at least. But it is a really devastating tumor, unfortunately. This is a medulloblastoma. This is something that occurs in pediatric patients. You don't usually see this as frequently in adults, so they can come around in like their 20s, 30s with this, but you much more frequently see it in pediatric patients. And where it is here growing in the, in this case it's in the, obstructing the fourth ventricle. It's kind of taking up the whole space of the fourth ventricle. It'll obstruct the flow of CSF from the lateral ventricles here and the third ventricle, which is at the midline, from doing its normal pattern of flow down around the spinal cord and up around this, outside of the brain. So the ventricles will become enlarged, and patients can have different kind of symptoms like, when patients have hydrocephalus where their ventricles are obstructed, they'll be, they say they'll be very wobbly, they are unsteady on their feet and that kind of thing. They'll obviously have headaches. They can have, changes in their vision, double vision, or, their eyes will not, stay still, this nystagmus where they kind of beat to the side uncontrollably and that kind of thing. And since it's pushing this is the cerebellum here, and if it pushes the cerebellum down here where it's at the base of the skull where it comes up into the neck, sometimes they'll have neck stiffness, where they can't really move as much there because they don't have as much space. So they do surgical treatment, they resect these, and they do radiation therapy and chemotherapy. And depending on how big it is and how much they can get out and everything, the kids actually do fairly well as long as they can get most of it out. This is an example of a lipoma. Lipomas can really occur anywhere in the body. Maybe some of you have them. They're really common. Even dogs get them. Sometimes people's dogs develop them, I know. It's just a kind of growth of a little lobulated area of fatty tissue. And it can occur in the brain, of course. The importance of using MRI in this case would be to just differentiate this from something that you need to worry about or do anything surgically about. So, these are T1 weighted images. This is usually how every MRI of the brain starts. As you know, you get this nice sagittal image. Look at all your midline structures, and this is a really typical location. As it's bright, like the fat and subcutaneous fat. It's really characteristic, and this is just an axial image showing the same thing. And this is nothing too much to worry about. Unless it's causing obstructive symptoms based on where it is, it's a leave alone thing. So good to characterize it well and then just forget about it. Don't follow it up. You can be done with it at that point. This is the meningioma that I mentioned earlier, can occur at that same angle, the cerebellopontine angle, where the cerebellum meets the pons, and kind of cause a confusion with the acoustic neuroma at times. This is a really kind of common tumor. You see these a lot. Sometimes they're symptomatic, and sometimes the patients will have had them for a long time, and they don't cause a lot of inflammation around them. They don't cause edema like the glioblastoma does. They can, sometimes get large enough that they cause mass effect pushing on the adjacent brain, but sometimes they're small and they're slow growing, and you just find them incidentally in old patients and you leave them alone. However, if they're big enough, if they're causing some compression of the brain, causing any neurologic symptoms, or compromising any of the ventricles or the vascular supply or anything, they may end up going in and taking them out surgically, or they may do that stereotactic radiosurgery that I told you about. Usually they go for surgical excision if they can, but based on location, they may opt for radiosurgery, which has a really good success rate as well. Even if sometimes they come back after surgical resection, which can happen, you can still subsequently go on to do radiation after that if you need to, or do another surgery. You have a lot of options with this one. Since it arises in the meninges, the coverings of the brain, it can basically happen anywhere in the coverings of the brain. And, even the ventricles are lined with like a brain covering. So you can see these in the ventricle. You can see them basically anywhere. Some of it's one of these things that we can usually fairly confidently diagnose based on imaging. So, we will, once you see it on CT, it has a certain appearance on CT, may have some calcification in it, it may be slightly, more dense than the brain tissue, and those are some things that would lead you in that direction. You may see changes of the underlying bone. If it's just under the skull, you can see some, scalloping of the skull that will point you in that direction. And you can, of course, give contrast with CT and, demonstrate this really bright enhancement. But these are MRI images, and of course this is showing, this really, really brightly enhancing light bulb bright, kind of like the one of those liver lesions I showed you earlier, the hemangioma on T2A imaging. Of course, this is with contrast, so it's a little different, but they call it, very light bulb bright. And this little thin tail that it has going off in each direction is called the dural tail, where, the tumor just kind of spreads out and thins out along the dura as it trails off. So that can really help you make the diagnosis. So once again, we like to do, a couple different planes of the post-contrast imaging, and, fairly high resolution if you can, especially if you're at the cerebellopontine angle. Make sure that you can get a good idea of its relation to the internal auditory canal. And, as far as surgical treatment goes, if they're going to do surgery, then, you want to characterize its relation to any of the other structures. Like in this location, of course, we're thinking about the superior sagittal sinus, one of the major veins of the brain that goes through there, and so you'd want to characterize its relation to that to see if resection is possible. And then if they go on to do the stereotactic radiosurgery, they usually localize that with CT. They'll do a CT scan of the patient's head when they're in like a certain steady frame, and then they match that CT scanner up with the radiation treatment machine that localizes the tumor really exactly. So, this is all really imaging dependent, and it's important for characterization as well as treatment. The patients do usually quite well with these. It's unusual for people to have problems with these. And similar with those renal cell cancers and stuff, sometimes in older people you may just leave them alone if they're asymptomatic. This is just another example of a meningioma in a different location. Obviously, this is going to cause a little bit more problem where it is. It's kind of pushing on the top of the spinal cord here, and it's going to obstruct the flow of CSF in and out of the spinal canal. So that one's got to go. So this is a pituitary adenoma. The normal pituitary gland sits in the sella and doesn't take up much space. This is an example of what we call a macroadenoma, a really large one that grows superiorly straight up out of the sella. They'll be pushing on the blood vessels that are here in the, the optic chiasm, giving the patient a very specific pattern of vision changes. These can also sometimes function and create, hormone imbalances that they may be detected just on blood tests, especially if they're small and they're not causing any mass effect. This is another one of those lesions that you want to really be able to describe, show it to the surgeon, its relation to the surrounding structures, the blood vessels and everything. Obviously, the optic chiasm, where your optic nerves come together and go back out towards your occipital lobes. So it's important to get good imaging of these. The other thing is there's also a lesion called a pituitary microadenoma. It just depends on, it's just an arbitrary term, whether it's big or small, just like micro and macro, like you would expect. So sometimes these lesions are really, really small, and they just show up as an area of slightly less enhancement than the rest of the pituitary gland. So when you're doing a specific pituitary mass protocol, MRI for this, you'll be taking, a few different planes, and, you'll take usually 3 different planes, thin section imaging, and sometimes more than one time point, just to see that, what, if there's any differential enhancement of the gland. Sometimes you'll never see where the actual discrete lesion is, and you'll just see that the gland is a little bit larger than usual, and they'll have to follow it based on the overall size of the gland rather than the size of the lesion. So if they're large and they're causing mass effect in the area, they obviously have to do surgery. They can do this surgery, through the nose, or they go, up under the lip. They can do this all, very delicately with imaging guidance, again, really helping them localize the tumor, and they have software that links up the imaging to the lesion so they can take it all out. And, the patients usually do pretty well. If it's a really small one, some of them don't function at all, and it's not a problem. Sometimes they function, and then they may have to give medications to counteract the function of it rather than do surgery. It really just varies, on the patient complaints and what kind of an effect you're having on it. This mentions something called pituitary apoplexy. This is kind of rare to happen, but it's something you'd worry about if you do have one of these large tumors. That they can be, kind of outgrow their supply and become infarcted and then bleed. And in that case, all this stuff kind of happens at once. If you're bleeding into it, then it gets larger and causes a lot of symptoms very suddenly. But usually these patients present with, slow onset of symptoms and, or abnormal blood tests, and they get taken care of surgically. Don't see that apoplexy occurring that often, though we talk about it in medicine a lot. This is a congenital anomaly, agenesis of the corpus callosum. This is another one of those things that just kind of happens in that embryologic stage where, everything has to happen exactly perfectly, or you can get anomalies later on. So the corpus callosum is, the joining of the white tracts from across the midline, and what you see in a normal patient is this, you see this little gray structure here on your, your first sequence T1 sagittal image. This is when you'd be looking at your structures, and you may not have complete absence of it, like in this patient. You see this, you don't see anything like that there, and then the ventricles assume this vertical configuration, and they're separated farther apart than a normal ventricles, or it may just be partial. You may just see, part of either the front or the back doesn't form. They don't have any treatment, once they develop it. You just have to manage any symptoms that occur, like if they have hydrocephalus or things like that from that. But, and then of course you want to look for any other developmental anomalies. This is the kind of thing that you'd be evaluating in a pediatric, pediatric age group. Usually, sometimes they detect this even on ultrasound before the baby's born, or on ultrasound after the baby's born. You can do an ultrasound through the soft spot on the head and detect it this way. They'll ask for MRI to really, further characterize it and look for any other anomalies. It can present with, other anomalies of, the way that the gray and white matter separates that can predispose patients to seizures and things like that. So you really want to, do a full and thorough examination. Once you see that, you can't stop and stop looking for things there. So always look for that on your, your T1 weighted sagittal images from the beginning of your study. This is another one that we usually see and evaluate in the pediatric pediatric patient. Another thing that we will often detect on prenatal ultrasound imaging called a Dandy-Walker syndrome. It's actually an abnormality of the cerebellum where this is normal cerebellum. It should meet in the middle and have this midline structure called the vermis. In this case, the vermis doesn't form, and you get this, big kind of cystic CSF density intensity area on it. So it just kind of looks like a really, really giant fourth ventricle. MRI is really useful in distinguishing it from another anomaly that can occur that's less serious neurologic consequences, which is have an enlarged foramen magnum, which is just basically the cerebellum is smaller, but it'll still have that vermis. So MRI can be really helpful in evaluating that, and also for looking for any other complications like hydrocephalus in the lateral ventricles and that kind of thing. So there's a continuum of these anomalies. Whether the patient has any symptoms or not kind of depends on how severe it is. Sometimes it'll be really subtle anomaly, and sometimes it'll be really large like this. So a lot of it has to do with like exactly what went wrong along the development, and so it can kind of stop at any part along the way, just like with the corpus callosum, and be a partial or a complete absence of the corpus callosum. This is just hydrocephalus. It's kind of a general term for enlarged ventricles. This can be caused by obstruction of the ventricles, like I've talked about with certain tumors and things like that, or it can be caused by overproduction of the fluid, the CSF, or in older patients you may see not really hydrocephalus per se, but enlargement of the ventricles, just because you lose some brain volume loss with time and everything, and so the ventricles may look larger. But you can see in this patient, when you know it's because of atrophy, if you see that the sulci of the brain get a little bit larger too. But in this patient, the sulci are pretty small and thin, and you see these big ventricles. So you start to think, this is hydrocephalus from either a communicating cause or a non-communicating cause. The imaging is going to be really important in detecting if there's an obstruction, where it is, and is there a lesion there that we could resect and relieve the obstruction, or is this just a case of too much CSF that just will be treated with putting a shunt catheter in. And I don't know if you've seen these in your imaging at all, but they can put a little tube in, and they connect the tube. A thin little tube will go down the side of your neck and down into either your chest cavity rarely, or more commonly into the peritoneal cavity. And that'll just, once it gets to a certain pressure in the brain, the fluid will just kind of drip down into the abdomen and get reabsorbed with any other body fluid. So it just acts as a valve to keep things, set. The patients, if they have hydrocephalus, they have a few different typical symptoms where they'll be unsteady on their feet. They'll act a little unusual, be confused or acting really strange, and incontinence is another symptom of this. So it is something that you want to look into if a patient's having that kind of constellation of symptoms. And then where MRI kind of, obviously you can see this kind of anomaly on, this kind of abnormality on CT, but where MRI kind of helps is on a T2 weighted image like this, or a FLAIR image especially, which is very sensitive to fluid. If you start to see some of the the bright signal creeping outside the ventricle, all the way around the ventricle, you start to think that there really is too much pressure in here, and the fluid is starting to leak out into the brain tissue, and that's called transependymal flow. And that means that this really is creating a lot of pressure in the brain, and should be relieved sooner rather than later. So that's an advantage that MRI has over CT for this. Here's a arteriovenous malformation. This is just another one of those developmental things where things just don't go exactly right, and you get an abnormal connection between an artery and a vein. And veins aren't used to the kind of flow, velocity, and volume, and everything that an artery produces, as well as the pulsation. So the veins will start to enlarge, and you'll get this really characteristic, kind of tangled up or bag of worms, kind of, they describe it, look of an arteriovenous malformation. And this is another typical appearance. They may not necessarily always be that small. So the way that the patients present really depends on where it is. Hemorrhage is often what brings these patients in. They may get hemorrhage. Sometimes these lesions will be big and obvious. Sometimes we may need sophisticated imaging, like doing the MRI with and without contrast, and different T2 weighted images and different planes and things like that. But sometimes it'll be really obvious, like these ones. And depending on where it is, what the symptoms are, they may do an embolization of it through the vessels, go up through the vessels in the neck and block off the feeding vessels, or they'll do surgery to resect it, or they'll do that stereotactic radiosurgery that I mentioned is good for other brain lesions. This is an example of intracranial aneurysm. You may have heard of aneurysms before as being like a kind of a catastrophic cause of bleeding in the brain, where the patient will have an outpouching of the blood vessel develop. This can often be this is often inherited in families, and it can be associated with some other syndromes, such as that polycystic kidney disease. They're at risk for getting aneurysm. So some people you'll see them coming in for MRI, MRA more frequently to evaluate for aneurysms, just to screen them and see if they have one, because the risk of this is that if it ruptures, the blood spills out into the subarachnoid space, and that's very irritating to the brain. It leads to a lot of edema all over the brain, causes the arteries to kind of clamp down, and the arteries are trying to stop the bleeding, but at the same time your brain needs blood. So it's really a difficult thing to manage when it happens if one of these ruptures. So we try to detect them in those kind of patients before they rupture. Sometimes patients will have what's known as a sentinel bleeding event, where an aneurysm will bleed a little bit, and then there will just be a little blood, but the patient will present with a terrible headache. I mean, it's very symptomatic. And then you have to think, maybe I need to do an MRA in this patient, and that the doctor will order an MRA or a CTA to find out if there's an aneurysm hiding in there, because you often won't see these on a conventional MRI or on a CT until they're very, very large. Once you detect them, whether they're ruptured or non-ruptured, the treatment would be to treat them through endovascular means. So they, using wires and everything going up through the neck vessels, they'll put a coil in to block off the aneurysm, or surgically they can do brain surgery and clip them off as well. Usually they try to do endovascular treatment, avoid a brain surgery if at all they can. So the way these patients usually present if they have a bleed, they say they have the worst headache of their life. It's a really dramatic event, and then neurologically they will deteriorate quite quickly. If it hasn't ruptured, some of these symptoms they'll have may be based on the mass effect where they are. They often occur at bifurcations of the arteries, so in this location they may compress around, they're getting near the optic nerves, so they may end up causing vision changes and different things like that. But unfortunately, frequently we don't detect them until they get a bleed in them. And this is an example of a certain kind of intracranial hemorrhage, and this is shown on CT, but you will obviously see this on MRI as well. In this case, it's a CT, and it shows blood is very bright on CT. It's all this bright stuff here. It's in the basal ganglia area of the brain that can frequently happen with high blood pressure kind of hemorrhage. Sometimes the blood will spill into the ventricles and pool in the ventricles here. Like on CT, on T1 weighted imaging, this is going to be pretty bright when it's new hemorrhage like this. As with time, it becomes less dense on CT. It also becomes a little less bright on. At first, it becomes a little more bright, and then it becomes a little bit less bright on T1 weighted imaging. But usually, we see these when they're fairly acutely, because they cause a lot of mass effect on the brain in the area, and they'll first be imaged with CT. Where MRI may come into play a little more often later is we'll recommend that when the patient's hemorrhage gets reabsorbed and resolves, and all the acute issues go away, we're going to recommend that they get an MRI with contrast to make sure that there's no lesion underneath there that caused this hemorrhage. Now, if it's in a characteristic location like this in the basal ganglia and the patient's blood pressure was, 250 at the time, you can be fairly confident. But if it happens in an unusual location, then you want to start to think about the possibility that it was, either a metastatic lesion that bled or something like an AVM that we can treat. And this is just showing the difference between a hemorrhagic stroke where there's a bleed versus an ischemic stroke where one of the blood vessels has been blocked off. And this is CT again, and it shows this, lower density area. Oftentimes you won't see the gray-white differentiation anymore. You see the gray is a little bit whiter than the white, unusually, but you'll see this as a really subtle change and know that there's been some infarction in this area. This is a little bit less obvious, but loss of the gray-white differentiation that you see over here. And MRI has become really, really important in the diagnosis of acute stroke because unfortunately even these subtle changes take hours to develop, and if they want to treat a patient with stroke with medications, they have to get them within a couple hours and get them treated. So now usually they, a lot of centers, they'll just do a CT, make sure there's no bleeding in the brain, and then they'll give the medication, which is a blood thinner, to try to open up the vessels and improve perfusion of the brain, and it often helps. But if they, have access to MRI and can get an MRI done rapidly at some of the more, the bigger university centers, we send them, straight to MRI, and they get a diffusion-weighted imaging. Diffusion-weighted imaging is the earliest imaging that we have to show it, where it just shows up as, very bright on diffusion-weighted imaging. So that'll usually be, your first or second sequence that you do, and then you can, let them know pretty quickly that there's a stroke. So yeah, MRI is much more sensitive. If they have time to go to get an MRI before they need to give the medicine, then we may suggest that to tell us definitively whether it is one or not. The patients that how well they do after having a stroke, maybe stroke is a pretty common illness, and it kind of depends on how much of the brain is affected, how much could be reperfused. Sometimes your brain can, there are other alternate pathways for the blood to get around, and it does well. Sometimes the patients do quite well with rehab and things like that, and sometimes it can be a really, devastating illness where it can take out a large part of the brain. So it depends on what how much area is involved and how quickly they can get treatment if they come fast enough. So one of the things that we've pushed in recent years is for patients, if they have any of those stroke symptoms, to try to go to the hospital as soon as possible. Don't really wait it out, because those medications can help save some of the brain tissue. This is just a larger image showing those changes. This is a brain abscess. This is a little bit less common than things like strokes and that, but it's another thing to look out for. This is going to remind you a little bit maybe of that glioblastoma multiforme, the GBM tumor, where there's a lot of enhancement around the edge, but usually the GBM has more enhancement in the center as well. This is really a ring of enhancement, but like the GBM, it creates a lot of edema around it on T2-weighted imaging. You'll see all this white, brightness, white signal intensity around it, because the bacteria are very irritating to the brain. And of course, on T1-weighted imaging, that's this kind of low signal intensity area there. Once again, if you see a patient come through with something like this, you may want to call the radiologist and say, hey, there's something really inflammatory going on here. Do you think we need to give contrast? And then once you give contrast, you can say, I'm really worried that this is a brain abscess. So they may have to do a craniotomy to get the abscess out. Abscess is often, the antibiotics can't always get into the abscess, into the center of the abscess, and get rid of it, if it's that large. So patients, may present with, just general, the same kind of neurologic symptoms that you would with any kind of space-occupying lesion in the brain, the headaches and changes in, neurologic symptoms and things like that. This is another kind of infection. This is a parasitic infection that causes usually a number of little kind of these ring-enhancing lesions similar to the abscess with a lot of edema around them. T2 weighted signal, that if you saw this, once again, you want to make sure that we're doing post-contrast imaging on it. You may just see one lesion, or you may see multiple lesions. This doesn't happen a lot in the States, but sometimes people who move here from other countries may end up showing up with this in our hospital, so we have to be ready to diagnose it. Usually the patients will present with a seizure just because it's so irritating. And this is just, like any kind of parasite. It often comes from, I believe it comes from eating undercooked pork, the Tenia tapeworm. So you always want to try to make sure you cook your pork well, according to the guidelines, especially if you're abroad. This is a big emergency. Those other, that other bleed I showed you, that wasn't taking up a lot of space, but you can see already that this is a very large area of density. This is CT once again. This is an epidural hematoma. This is something you would rarely diagnose on MRI because usually these patients come in, with really major symptoms, maybe, lost consciousness, had trauma, probably they often have a fracture of the skull and have damaged one of the epidural vessels here. And that creates, because it's an arterial bleed, it creates really a lot of blood in a small, in a small space in a small amount of time. So this is a major surgical emergency. As soon as you see this, the patient needs to be kind of basically taken to the OR to decompress it. And if you get it, if you get the patient evaluated and CT really quickly, take them right to the OR, they'll usually do okay. But we're imaging a lot of trauma patients now, imaging the head pretty readily and trying to look out for really major things like this. This is a little bit more common than epidural hematoma. This can occur with much less dramatic trauma. It doesn't necessarily take a skull fracture or major trauma to do this. You'll often see it with older people. They can just, fall from standing and get a subdural hematoma. So it just the blood kind of accumulates in the subdural spaces. And unlike that epidural hematoma that looked like it was convex, these stay concave. So they look more like a C shape conforming to the inside of the subdural spaces. In this case, it's bilateral. The reason that older people are a little bit more at risk of these is because as your brain kind of atrophies with age, the veins that drain, the draining veins, the dural veins get stretched a little bit, so they're more. This is a venous bleed, so those veins are more at risk for rupturing in that case and creating a subdural hematoma. And the symptoms can be really confusing. The patients may have headaches, they may be acting funny, or they may just find this incidentally, because the patient was there for another reason. But we kind of have a low threshold for scanning, especially in an older patient, even with a minor trauma, to look out for stuff, something like this. And a lot of these will resolve on their own, and you could just do sequential imaging and see how they do. But some of them will require, craniotomy to drain the blood out if they're creating too much mass effect. You can see these are getting a little bit large, but you may see these on MRI, just as a follow-up. But typically, this is another thing that we usually we do CT for diagnosis and follow-up. Another kind of hemorrhage. This is a subarachnoid hemorrhage. When I was telling you about aneurysms in the brain, this is the kind of hemorrhage that they will lead to, a subarachnoid hemorrhage. These are all different spaces in the brain, and you just kind of remember what the pattern is. This one, if it comes from an aneurysm, it'll be in this characteristic pattern, around the basal cisterns at the base of the brain. And so if you saw this pattern, you'd want to do an MRA to confirm it, so that the patient could potentially get aneurysm treatment either by surgery or by endovascular treatment. Sometimes this can occur from trauma as well. In that case, you don't see it in this location around the basilar cisterns. You just see these little hyperdensities creeping into the sulci, usually, around the area where the trauma was. So if you see a bump here, you start to look for the subarachnoid hemorrhage here. If they're, they've got a big lump on their head. And then there's also the thing known as the contracture injury, where there's whenever you have a bump here, there's a little bump in the back too, as a reaction. With the brain moving inside the skull, so you got to look, on the other side too. I mean, generally we obviously look at the whole brain, but that's the kind of pattern that you'll be looking out for when you're looking for a traumatic kind of subarachnoid hemorrhage. And those are the main causes. AVM could, sometimes cause it, but that's certainly not the most frequent cause. These will cause that severe, worst headache of my life when it occurs, and it's very irritating to the brain. And the prognosis once again depends on how much blood there is, how irritating it is to the brain, and how much swelling there is in the brain. Sometimes they'll take off parts of the skull just to decompress and give that brain some room to swell until things start to settle down. It involves a lot of blood pressure control and try to keep the brain perfused, but not irritating it. This is some MRI images of multiple sclerosis. MRI is really important for multiple sclerosis imaging. What you usually see is you're looking for this on FLAIR imaging. You'll see a lot of this abnormal signal in the white matter as patients get older, just these scattered dots and everything. But if you're seeing this kind of an appearance in a 40-year-old, and especially if you see these kind of horizontal ones, they're not random scattered dots, but you see these kind of horizontally projecting ones, you start to think about MS. And MRI is really helpful not just in detecting these lesions, but also telling us whether they're, this is a demyelinating disease, so you want to know if there's any active demyelination going on that you can try to intervene with, or at least control the symptoms of, and know how active the MS is being. So we do post-contrast imaging for this. So this is another one that you may want to suggest post-contrast imaging if it wasn't already ordered. And diffusion-weighted imaging, if you don't do it as a routine, can also show when there are active MS plaques. Now, if there is a plaque, it will always show up on the FLAIR imaging, but once it's not active anymore, it won't enhance and it won't restrict diffusion. So a lot of this a lot of the treatment is based on symptoms. They may use steroids, and it may just need therapy, just trying to manage whatever neurologic symptoms come as a consequence of it. This is another congenital malformation. This is where this is the cerebellum here. These are the cerebellar tonsils. Sometimes they'll end up herniating down a bit too low. They should end here. They shouldn't be joining the spinal canal down through the foramen magnum. So this is something we always want to look for on our T1 weighted images. And the risk of this is, this can cause some obstruction and hydrocephalus. And so sometimes they'll just take a piece of the skull off back here and just create some room in this area. Sometimes they may need a shunt in order to decompress the ventricles that are being blocked off by it. So that's it for the brain pathology. I think I might have to leave musculoskeletal because I guess it's already been the couple of hours. But do you guys have any questions about the other PowerPoints that you looked at? And any questions about certain disease entities? I think the information in the packets is pretty good. Just when you go out there, just make sure that you're keeping an eye on the scans as they're being done. It's always embarrassing to have to call a patient back because just